Next I will call Dr. Bhartendu Kumar. His topic is hand hygiene.
Respected chairperson, sirs, seniors in the crowd, if there could some be,
You are the most senior.
and friends. Continuing with this safe surgery, let us talk something about hand hygiene. Probably it is known to each and one of the audience, and everyone almost practices it, but let us examine if we do it correctly. Do you want your hands to offer hope and healing? Or do you want your hands to help spread itch, hospital-acquired infection? Hand hygiene is to be described, is to be seen in that perspective. You are also more susceptible to carrying around infectious organisms. 80% of the staff who dressed MRSA wounds, methicillin-resistant Staph aureus wounds, carried the organism on their hands for 3 hours afterwards. And 60% of the hands of the staff within half-hour contact with Clostridium difficile were contaminated without even touching the patient. Mark it. Meanwhile, washing with simple soap and water in these cases virtually eradicated this organ. So how important hand washing even after touching a patient or even after being in the same room as the patient with Clostridium difficile is. Hand transmits healthcare associated infections, or we can call them nosocomial or hospital infections. These are the infections occurring in a patient during the process of care in a hospital which was not present or incubating at the time of admission. This is the definition. This includes infections acquired in the healthcare facility, but it may appear after discharge also, and also occupational infections among healthcare workers of the facility. That is, we can also have the infections, and that could also be labeled as healthcare associated infections. What is the global epidemiology and its impact? The impact we know. It causes more serious illness. It prolongs the stay in the hospital, long-term disability, financial burden is definitely heightened, and there is a high personal cost on patients and their families. Look at the picture. The person has lost the leg only because of hand infections produced by lack of hand hygiene. Almost 5 to 10% of patients acquire one or more infections while in the hospital, and in developing countries this can go up to 25%. So even developed and modern healthcare facilities also do have patients or do have persons who get hospital-acquired infections. In ICUs, even in modern places or modern facilities, this HCAI goes further high up to 30%, or mortality may reach up to 44%. So what are the most frequent sites of infection and their risk factors? Most common sites of healthcare associated infections, they could be urinary tract infection, it could be LRTI, lower respiratory tract infection. It could be SSIs or surgical site infection, or it could be blood infection. And all these may be attributable to lack of hand hygiene. So how do we prevent it? Before knowing about the prevention of STIs, let us examine what are the ways and why we simply skip washing our hands. The premises are, the professional is too busy. So it should be made into your habit. It is essential that you make time for it. My skin irritates. Then use lotions and rubs which do not irritate. Have a substitute rather than stopping it altogether. Glove. I use gloves. So what is the basis? What is the reason for washing my hands? Glove, my dear friends, is not a substitute for hand hygiene. And it is not always on the top of your mind. So it should be made a habit so that it becomes as spontaneous as using aseptic technique and all other safety strategies. So by these, only by maintaining hand hygiene, we can prevent almost 50% of healthcare associated infections. There has been many studies, the most famous being the Scenic study, which shows that more than 30% of ACIs are very much preventable. So why all the fuss about hand hygiene? It's the most common mode of transmission of pathogens. And infections acquired in healthcare and a spread of antimicrobial resistance. Even the antimicrobial resistance have some relationship with lack of hand hygiene. Hands are the most common vehicle to transmit healthcare associated pathogens, because transmission of healthcare associated pathogens from one patient to another via healthcare worker stand requires 5 sequential steps. Number 1 is, it is not visible probably. The number 1 is the germ is present on patient's skin and immediate environment surface. The second stage is the germ transfers on healthcare worker's hand. Third step being the germ survives on hands of several minutes. For several minutes, again it depends upon the germs, whether it survives for 30 minutes or 3 hours. But they have been seen to survive for almost 3 hours. And this suboptimal or omitted hand cleansing results in hands remaining contaminated, and this contaminated hand transmits germs via direct contact with the patient or patient's immediate environment. So these are the reasons why one should clean your hand. You must perform hand hygiene to protect the patient against harmful germs and also protect yourself and the healthcare environment from harmful germs. Hand hygiene is one of the most effective measures to reduce the occurrence of HCI. It takes less than 1 minute. Now mind it, it takes less than 1 minute to properly wash hands using soap and water, and less than 30 seconds to properly clean hands with alcohol-based hand rub. And both methods are effective. Even alcohol-based hand rubs for 30 to 40 seconds is equally effective. Rather, it is nowadays a preferred method. So either you clean your hands with soap and water or alcohol-based hand rub in order to remove microorganisms. And when do you perform hand hygiene? Number 1 is before initial patient or patient environment contact. That's going before surgery or even going into an ICU setup, before aseptic or clean procedures anywhere in the wards, in OT, in ICU, wherever, and after the blood fluid exposure risk, and after the patient or patient environment contact. These are the 4 situations where hands must be washed. So hand rubbing with alcohol-based hand rub is the preferred routine method of hand hygiene nowadays. Hand washing with soap and water is also very important in situations where the hands are visibly dirty or soiled, or if there is an exposure to a patient or environment where Clostridium difficile is there, hand wash is preferred. That is, soap and water hand wash is preferred over alcohol-based hand rubs. These are the only 2 situations where soap and water have edge over rubs. So how to hand rub? These are the methods. These are probably there in almost all the operating rooms. So these have to be, all the steps have to be followed. This is important. And it takes not more than 30 seconds to rub with alcohol, that is 60%, minimum of 60% of ethyl alcohol, and it serves the purpose. Similarly, with hand washing, it must last 40 to 60 seconds, and again the same sequence is to be followed as was followed for hand rub, and it is there in every chat. Or we can go through various sites. There are YouTube sites. You can download and practice it. Soap and water is the recommended method when hands are visibly soiled. Plain soap is used for routine hand hygiene, while antimicrobial soap is used in acute care high-risk cases. Antimicrobial, I mean triclosan or such type of soaps. Lifebuoy or the red soap is, for that matter, is not an antimicrobial. When I describe antimicrobial soap, I mean I want triclosan. That is the commonest antimicrobial soap. That has some health issues, but still once for a while, when it is visibly soiled and you are going to a high-risk area, that should be used. Artificial nails, gel nails or extenders are not to be worn by staff who have direct patient contact. Contaminated surfaces or objects should not be touched after performing hand hygiene. Avoid touching your face, especially your eyes and nose. Many a times one does this mistake of touching eyes and nose. This shouldn't be done. Fingernails should be kept short, no longer than 0.635 centimeters. I don't know how to measure it, but it should be something around 1/4 of an inch. Nail polish you can wear, but it should not be chipped. If it is chipped, it should be removed. Hand and wrist jewelry rings, a big no. Do not a partially used high hygiene product dispenser. Again, it is a very common habit of topping up the dispenser. You shouldn't. You go for a fresh one, or if it is a reusable dispenser, it should be emptied, washed and dried prior to being refilled. Hand lotion bottles must never be reused. Include frequently missed areas when performing hand hygiene, such as thumbs, palms, web spaces, under nails and the backs of fingers and hands. Use supplied lotions that are compatible with hand hygiene and that products minimize skin irritation. You may be hypersensitivity to certain which the other staff may not be. So change your hand hygiene method and allow the other staff to be washing their hands with the supply from the hospital. Hand hygiene and glove use. The use of gloves do not replace the need to clean your hands. You should remove gloves to perform hand hygiene when an indication occurs while wearing gloves. And thank you for patient listening.
Thank you, Dr. Bhartendu, for your excellent deliberation on safe hand and safe life. I next call upon Dr. Narayan for his next topic is this, the art of the safe surgery, safe life. Dr. Narayan, MP from Patna, Bihar. Safe surgery.
Mr. Chairman, sir, dear colleagues, my dear students, ladies and gentlemen, I am grateful to the association members for giving me an opportunity to talk on a subject which is in our day-to-day life. Safe surgery saves life. Safety everywhere and safety every time. Look at this aviation tragedy of the Korean Airlines, lot of lives lost just because there was miscommunication between the first and the second pilot and they didn't adhere to the checklist. And here comes the value of the checklist. You pay heavily for the safety lapses. Look what has happened if you don't stick to the safety procedures. Safer surgery saves lives. The first conference was held in Geneva, Switzerland, 11th and 12th January 2007. And over 50 participants around the globe were there. And the WHO had met 10 objectives for the safe procedure. First, the team will operate on the correct patient on the correct site. The team will use methods known to prevent harm from administration of anesthetics while protecting the patient from pain. The team will recognize and effectively prepare for life-threatening loss of airway and respiratory function. The team will recognize and effectively prepare for risk of high blood loss. The team will take care of known allergy and drug allergy. The team will consistently use methods known to minimize the risk for surgical site infection. The team will prevent inadvertent retention of instruments and sponges in surgical wounds. The team will secure and accurately identify all surgical specimens. The team will effectively communicate and exchange critical information for the safe conduct of the operation. Hospitals and public health systems will establish routine surveillance of surgical capacity, volume and results. This was designed by WHO. Now let's see how many of us are exactly adhering and how many hospitals are exactly adhering to these. What are the strategies of safe surgery save lives? Promotion of surgical safety as a public health issue, improving communication and team building to ensure safe surgery, creation of a checklist to improve the standards of surgical safety, and collection of surgical vital statistics. What are the problems? The three basic problems are unrecognized as a public health issue, lack of data on surgery and outcomes, even though we know what to do, but we don't do it consistently. Problem one is burden. There's a big burden of surgical disease increasing all over the world. See, because of these surgeries, there are known surgical complications and known death rates. Therefore, at least 7 million disabling complications, including 1 million deaths worldwide each other. Problem two is improvements in maternal mortality dependent on routine surveillance. We had a surveillance and we acted on that, and that led to a decrease in the maternal mortality. But unfortunately, such surveillance is lacking for surgical care. And problem three is high rates of preventable surgical site infection results from inconsistent timing of antibiotic prophylaxis. Anesthetic complications are higher in countries that do not adhere to monitoring standards, and wrong patient, wrong site operations persist despite high publicity of such events. How to implement? What is the implementation strategy? A building of a team. Commitment by team members is essential. Tell your colleagues about the checklist. Start with those who are likely to be most supportive. Identify a core group to involve at least one member from each of the clinical discipline. Work with those who are interested rather than trying to change the most resistant people. Meet with hospital leaders. Support of this initiative by leaders in each of the clinical disciplines is critical to its success. Think about what the hospital leadership can do to promote the checklist. Start small, then expand. Run a campaign in specific settings. Start small, one operating room with one team. Move forward after problems have been addressed and when enthusiasm builds. It will come gradually. All we have to do is to make a practice of it. Use the checklist. Core team members must be using the checklist in their own operating rooms. Slowly encourage others to adopt the checklist. Work through potential concerns. Do not hesitate to customize the checklist for your settings as necessary. But do not remove safety steps just because you are unable to accomplish them. Set public goals. Once you have sense of your data, try to improve your numbers by letting your whole hospital know about the improvement goals you hope to achieve. Update the hospital on progress. Make the progress on both process and outcome measures publicly available so that hospital staff can witness improvement. What you are doing should reflect that it is being done. Continuity is essential. Continue to use the checklist. Data collection may become less frequent as the checklist is accepted. A periodic check on progress will ensure the process measures stay on track and complications are minimized. These are the 6 A's that can check commitment model is awareness, agreement, acceptance, action, accountability and assimilation. They are the 4 categories for surgical standards. Then let's come to the checklist. How the pilot's checklist came about. You see anybody, any flight which takes off, there is a checklist and pilot 1 and 2, they go through each and every item. And once they declare that the checklist is okay, then only the flight takes off. The same thing we have to keep in our theatres also. We have to have a checklist and check before starting the surgery that and adhere to the list that everything has been followed. So components of the checklist, these are the wordings which have been fixed by WHO. Checklist is divided into 3 components, that is briefing, before induction of anesthesia, time out is before skin incision, and debriefing is before patient leaves OT. What is briefing? At a minimum requires presence of anesthesiologist and nursing, performed before induction of anesthesia, and performed with patient awake participation. Briefing is for the consent of surgery, the type of procedure planned and the site. It is with consultation with the patient in presence of the surgeon and the nursing staff. Site marked, then the equipment, instruments and implants which are to be used in the theatre. They must be checked before the anesthesia or the surgery starts. Otherwise this hanky-panky, what happens that we start and then we are shouting that this is not available, the implant has not arrived, this cataract is not there, this is not this. So if this is done earlier, there will be no problem. That's the part of briefing. Anesthetic safety checklist is again there for our anesthetic friend, for the difficult airway, for the risk of blood loss, post-operative destination. At this point the briefing is complete and the team may proceed with induction of anesthesia followed by positioning, preparing and draping. Time out is the word which is used, say after the briefing and start of the anesthesia, performed after induction, preparing, draping immediately prior to surgical incision. Completed in accordance with WRHA policy, correct site, correct procedure and correct patient. This is so important. So many problems, so many legal complications have come up just because we don't adhere to this correct site, correct procedure and correct patient for surgical procedure. And once the anesthesia is given, then before giving incision we must, with the team members are identified consisting of surgeon, anesthetists and nurses, and again we have to confirm verbally that correct patient, correct procedure and correct site is being followed. Antibiotic prophylaxis given within the appropriate time frame, essential imaging displayed, confirmed essential imaging has been displayed and is displayed correctly. Team communicates anticipated complications. So before we start, we must communicate with each other that what complications can be there so that we can prepare for that. Stop, does everyone agree we are ready to go? And at this point, the time out is completed and the team may proceed with the surgery. Now debriefing at a minimum requires surgeon, anesthetists and nurses to be present, performed during or immediately after the wound closure before the patient is transferred from the operating room, should be initiated when informing the surgeon that count is correct. This is so important. No patient should be out of the theatre unless the sister says that the count is correct. Otherwise, if any doubt, we should get the X-ray done before referring the patient to the ward. Nurse verbally confirms with the entire team verbal confirmation of specimen details, verbal confirmation of surgical count and identification of equipment problem. Surgeon reviews with the entire team summary of important intraoperative events and indicates management plans. This is anesthesiologist review with the entire team, and if there is anything we could have done better, before the patient leaves, we should think what we did or what best we could have done to improve the situation so that in the next case the thing is not repeated. Safety checklist is now complete and here is the reality check. Currently hospitals do most of the right things on most patients most of the time. But dear colleagues, the checklist helps us to do all the right things on all patients all the time. This is the surgical safety checklist. I will request all of you that is of a WHO, you can download from your net and please keep it in your theatre so that in our day-to-day practice we can just follow it, and I can say with confidence that it will save you as well as the patient most of the times. There have been many pilot studies on it. You see, so many countries have done pilot studies on this, and at the end they have found that everybody was asked a simple question that if I were having an operation, I would like the checklist to be used, and the answer was positive in 92.6% cases. So last but not the least, I would like to quote that we are good at making sure we do most of these things most of the time, but we are not good at doing all of them all the time. I will quote again of Alex Hines, because each slip represents an opportunity for harm to your loved ones. So dear friends and colleagues, again I would request you to stick to the WHO checklist, and I am confident that we will be successful most of the times. Here is you see the poor man is out of the ambulance because the road clarity was not there. The another problem in our theatre or in our hospital, that the clarity of the road is not there. Who has to do what? That should also be must and designed much before the surgery starts. Here, the man who was supposed to close the door, his road clarity was not there, and the ambulance started, and the poor man is out of the ambulance. So it is our job to see that the correct persons are at correct places and the correct procedures are followed to have a safe surgery to save life. Thank you very much for your patience.
Thank you very much, Dr. Naran. You have really talked on the subject very well. Safe surgery really saves life. Thank you so much.